Good afternoon and welcome to PBA at noon. I'm Paul Benwell and I'm joined by my colleague and associate Sophie Caesar. We are continuing our health focus theme with one of our favorite companies. It's Reliq Health. Reliq first presented with us in October of 2000. Hi, Lisa.
Hi.
In October of 2017 at one of our 5 Cassette cocktails in Montreal. For those of you new to the company, Reliq Health Technologies is a healthcare technology company that specializes in developing innovative solutions, software solutions for the community care market. They have had their ups and downs and had to adapt like everyone else through this pandemic, but this has put them in a great position for growth. And today we have with us the CEO, Lisa Crossley. Reliq trades on the TSX Venture under the symbol RHT. Hi, Lisa, great to see you again. And start whenever you're ready, and we'll have some questions for you at the end.
Okay, thanks, Paul. Thanks, Sophie, for having me back. And apologies to anyone and everyone who tried to attend my last PBA at noon. I managed to get the stomach flu, despite the fact that we go nowhere and see no one, but it ravaged our household and managed to hit me right before that webinar. So everybody's healthy today. We shouldn't have any of those issues. Thanks very much for having me back. And I will go through our brief overview presentation and then be happy to take questions. So there we go. If anyone has any trouble seeing my screen, wait, I haven't shared yet. One sec. Zoom, share screen. All right, just get that into slideshow. There we go. All right, if anyone's having trouble seeing my screen, Sophie or Paul, please let me know.
Looks great, thank you.
Okay, thank you. All right, so welcome to our corporate overview presentation. Forward-looking statement disclaimer, please feel free to review this at your leisure. I will not be reading it now. So Reliq Health, as most of you probably know, or at least some of you probably know, we're a global telemedicine company, essentially, at our core. We have our headquarters in Hamilton, Ontario, but we also have US offices in Texas and in Florida. And the company's largest customer base is certainly in the US, and so we have a fair number of resources down there. And our target market is the $100 billion virtual care or chronic disease management market. So we talk a lot generally about being a company that serves the community care space, and community care really just means anything outside of the acute care setting. So if you're not in the hospital, essentially you're receiving care in the community, whether that's from a skilled nursing facility that does short-term rehab, or you're receiving home health, or you're seeing your family doctor. That's all considered community care. So it's a very, very large setting for healthcare. And increasingly, particularly over the last 3 to 4 years, Medicare and Medicaid have really been pushing care out of the acute care setting and into the community. We're starting to see a tiny bit of that here in Canada, but not nearly as much. But really in the US, between the government funded payers and the private insurers, they've really been trying to push care out of the acute care setting, where you're really just kind of putting out fires, into the community, where you have more of a potential to impact health from an upstream perspective before critical issues arise that require hospitalization. A little tiny bit about our team. Again, I won't read these slides to you word for word, but myself, this is the 4th company that I've run as CEO. We recently hired, well, maybe not that recently anymore, but about a year ago, we hired a new CFO, Matt Lee. Matt has tremendous experience with publicly traded companies, and particularly with companies that have their market focus in the US. So that's been very, very helpful to us. And I'll just note here that along with bringing Matt on a little over a year ago, we also changed auditors to KPMG. And we've certainly found that having one of the big 4 firms involved with us has been hugely helpful in terms of helping the company to strengthen its processes and transparency with respect to everything in terms of finance. And then I'll just quickly our latest addition is our US Chief Medical Officer, Joyce Johnson. And Dr. Johnson has been exceptionally helpful in terms of producing care plans and helping us to navigate some of the complexities of Medicare and Medicaid. So the problem that we're solving as a company is really around the chronic diseases like diabetes, hypertension, kidney disease, chronic obstructive pulmonary disease, congestive heart failure. And these chronic conditions, we have about 20% of the population in any of the developed nations who have chronic diseases. There are certainly pockets where that number is much higher, but on average, about 20% of the population have chronic diseases. And that accounts for up to 80% of our healthcare spending. So really, we have this small percentage of the population who are the ones who are really driving healthcare costs. And as the population ages and grows, that becomes an increasingly significant issue. So in the US alone, last year, they spent $3.6 trillion on healthcare. And that means that the chronic disease spending was close to $3 trillion. And that's 18% of their GDP they're spending on healthcare. So it's a very significant cost. It's relatively similar up here and in most developed nations. So, what we've tried in the past in healthcare, which is really focusing on that acute care setting and closing smaller hospitals or reducing the number of beds in hospitals, that really amounts to essentially rearranging the deck chairs on the Titanic. So that's not going to fundamentally affect or impact healthcare spending. And what really needs to happen is something that moves the needle on the way these chronic disease patients progress in their disease. Now, chronic disease patients tend to have poor overall health outcomes. And the reason for that is that on a day-to-day basis, they're responsible for managing their own care in the home. And they tend not to do a great job of it. Most of these patients are older. I think our average patient on our platform is over 75. And many of them have 2 or more chronic diseases. Some of them have 6. And so they're quite ill, they're elderly. And they're not very good at managing, taking their vital signs on a regular basis if left to their own devices, or in acting on the data that they're getting when they collect their vitals. Less than 50% of these patients take their medication as prescribed, and that alone, just fixing that problem, prevents a lot of hospitalization. If you're an elderly patient and you're not being monitored in terms of medication compliance, you might one day miss your high blood pressure medication, the next day take twice as much. That can result in a fall or potentially a stroke or a cardiac event. But often that is what leads to things like broken hips, is they just took too much of their high blood pressure medication, blood pressure went too low, and they got dizzy and fell. And over the last few years, really starting about 5 years ago, but it wasn't until 2019 that we really saw a significant shift with Medicare and Medicaid. They're the world's largest payer in healthcare. They're certainly the US's largest payer, meaning the largest insurance company, if you will, in the US in healthcare. They're government funded, and we call them CMS. It stands for the Centers for Medicare and Medicaid Services. And CMS really started to get on board about 5 years ago with a move away from fee-for-service care to outcome-based or value-based payments. And so what that means is, historically, as a physician, you would make more money if you had a patient who came to see you very regularly than if that patient remained in exceptionally good health. So you can see where that outcome is really disconnected from the desired outcomes of the healthcare system. And so CMS moved a lot of their payment models to things like shared savings. So if you were operating an accountable care organization, big family practice, you'll get to keep half of the savings that your practice has for its patients relative to the average practice with Medicare and Medicaid patients. And where it really has impacted us is that Medicare and Medicaid have continued to add billing codes, reimbursement codes that cover our services. When we started with patients in 2017, there was really only one code available to bill for our patients, and reimbursement was relatively low. And as many of you know, in 2018, fraught with challenges as Medicare introduced a new code, and there were a lot of subjectivity from Medicare and Medicaid in terms of what they would and would not reimburse, and very little guidance provided up front. So it created a lot of confusion in the market. But beginning in 2019, they clarified those billing codes. They added a number of billing codes, and every year since, they have continued to add billing codes. So they've basically continued every year to double down on their investment in virtual care. So they now have codes for remote patient monitoring, chronic care management, transitional care management. These are really all essentially just a way of monitoring patients remotely, but with a different focus. So it might be post-discharge from a skilled nursing facility after you've been in for 6 weeks for a broken hip or open heart surgery rehab. But there's quite a broad range now of ways, including behavioral health integration for mental health, that Medicare and Medicaid now, excuse me, compensate clinicians based on outcome. And that's really where we come in. We're able to drive those better outcomes and better patient engagement. And so we have been very fortunate in that, particularly over the last 2 years, the market dynamics have changed substantially. And the one benefit to come out of the pandemic is I do think it's really accelerated the acceptance and the adoption of virtual care by a decade easily. And so this coming year, really, there's just an enormous market that we're no longer the missionaries and the pioneers, and we're really at the point where we can be the settlers and take advantage of our first to market competitive advantage in that space. So what do we do? Our iUGO Care platform, and that's our cloud-based software as a service platform, and it supports remote patient monitoring as well as these other modules called chronic care management, telemedicine's here, transitional care management, behavioral health integration, which is just around mental health. And so that's not one of the classic chronic diseases, but it is definitely a chronic condition that has a huge impact on healthcare spending and on quality of life. So our platform allows clinicians real-time access to patient vital signs from in the home. It also supports virtual consults, much like this, only in a HIPAA-compliant manner, and they can document as they go. And it allows clinicians to intervene early if patients start to have any issues before that patient needs an acute care visit, either an ER visit or a hospital stay. So this is just kind of a look at a dashboard that one of our clinicians might see. And what they can track here are whatever patient vital signs they feel are meaningful to them in terms of guiding that patient's care. But most importantly, because we don't expect that physicians are going to log on every day and check on all of their patients, it's just not realistic, especially lately during the pandemic when they're so overwhelmed. So what we do is we deliver automated alerts to the clinician. So if there's an out of norm result, for example, with a congestive heart failure patient, if they have a sudden 2-pound weight gain over 24 hours, that's indicative that they're going into heart failure. And if you intervene right away and change their diuretic medication, you can keep that patient healthy and at home indefinitely. But if you wait until the patient starts to experience symptoms like chest pain or pressure, difficulty breathing, at that point, they're probably looking at an ICU stay. And ICU stays cost hundreds of thousands of dollars. And generally, patients who go in have experienced enough physiological damage that they're not coming out the same. So you really want to be able to catch those early markers that seem very minor, but that are only caught when you have daily monitoring, and intervene at that point. It's a huge help to the patient in terms of quality of life, certainly huge impact on health outcome, but also a really significant impact on reducing healthcare spending. I won't dwell on this since most people who aren't cybersecurity experts aren't terribly interested in this, but we have a very secure platform. It is cloud-based. All of the data lives in the cloud. We're hosted by Amazon Web Services. A lot of redundancy, so we don't have to worry about downtime. And our platform, it automatically pulls data from the devices in the patient's home. And we can plug and play essentially with virtually any device. So we're able to collect data over cellular networks, which is an issue in some of our more remote and rural communities where they don't have conventional internet access at all. And so we pull data over cellular. And the data is compressed, and it's relatively small packets of data anyway. So even with sketchy cellular connections like we've had in Northern Ontario, we're still able to pull that data using cellular, or we can use Wi-Fi or Bluetooth enabled devices. We also recently announced that we can use interactive voice recognition. So essentially, if you have a patient who has a non-connected device, they have an old school analog scale, or they've got a thermometer, mercury thermometer, and their clinician wants to track them for potential fever because of COVID. We will have this interactive voice platform that basically dials the patient and has a conversation with them, collects the data, and whatever data they provide is automatically transmitted to our platform. So clinicians will still receive alerts for those patients, even though they're not working with some of the more recent or current technology. So our business model. So the most important thing to understand is that we have patients that we onboard onto the platform. So the patients are the ones who are receiving the service. They're the ones whose data we're collecting. But it's the clinicians who are our payers. So the clinicians themselves receive payment from, for the most part, the Centers for Medicare and Medicaid Services, although in some cases it's an employer-sponsored health plan or private insurance company. But the clinicians are the ones who pay us. We are targeting the patient population and therefore the clinicians who care for primarily that 37 million Medicare and Medicaid patient population who have 2 or more chronic diseases. So it's quite a large patient population. The US market for what we do is worth over $100 billion. And so it's a very significant market, and it continues to grow as the patient population, as the population in general ages and grows. And I'll just quickly touch on our subscription fees. We started out, the subscription fees were kind of averaging around $25. As CMS has added more and more billing codes, and we're therefore providing more modules, more services to clients, our average revenue per patient or per user, you could call it if you're used to a more traditional SaaS model. But our average revenue per patient right now is around $40 US per patient per month, but we do expect that average revenue per patient to increase as we move forward, because we are being asked to offer more and more of these modules as more billing codes come online. So we'll have patients who are on the platform who are receiving multiple services, and in some cases from different clinicians, but all using our platform. But for now, our average revenue per patient is $40 US per patient per month. So the benefits of using our platform, I think I've been clear already that you see significant improvements in health outcomes, and that obviously translates to improved quality of life, not just for the patient, but for their family members, their loved ones, their informal caregivers as well. And we reduce hospitalizations, we improve medication compliance. You can see a drastic/dramatic improvement in medication compliance with patients on our platform. And that in turn has a really significant impact on health outcomes. And surprise, surprise, just taking your medication is very important. And we also find that patients really embrace the platform because they feel that there's that safety net there for them, and they don't feel as alone. A lot of patients will describe chronic disease patients, going in for a hospitalization and receiving all this care, and then going home and feeling like they fell off a cliff in terms of the healthcare system. So knowing that there is that daily accountability really tends to engage patients and empower them. And so we consistently see statistically significant improvement in healthcare metrics, as well as a statistically significant reduction in hospitalizations and ER visits for patients who are on our platform. So the nice thing for the US clinicians in particular is that while we're charging around $40 US per patient per month, that no more than $100 US per patient per month, no matter how many services we're offering, the clinician can receive at least $315 US per patient per month by implementing our services. So Medicare and Medicaid have designed the system such that clinicians do make more money if they implement virtual care solutions. So this is actually new revenue for the practice. It's primarily profit. We take a relatively small piece of that in terms of what they're paying for the platform. So there's a strong financial incentive for clinicians to implement virtual care. That incentive has gotten much, much stronger over the last year. So there's a significantly larger budget, and that continues to increase every year. That for clinicians, not that most of them aren't wonderful altruistic human beings, but certainly having that financial incentive is very helpful to us in terms of selling the solution. And what Medicare and Medicaid have found through their statistical analysis of the last few years with virtual care is that it translates to a tremendous cost savings. So where you would have the average chronic disease patient would cost a minimum of $12,000 a year to the healthcare system. On virtual care, you can drop that cost to less than $2,000 typically. But if that patient were to have an ICU stay, you're looking at hundreds of thousands of dollars. So for some patients, the difference is between 250, 300,000 a year down to a couple of thousand a year. So this is something that Medicare and Medicaid sees as a way for them to continue to exist, to have the financial wherewithal to continue to offer their programs long term. So they've been very, very progressive, and we don't have this in Canada yet, but about moving care upstream and having it be value-based, and that plays perfectly into our business model. Customer traction. So we have clients and partners who operate in all 50 states in the US. Right now, our largest patient populations, we've certainly had quite a few in South Texas and Florida. Historically, last year with the pandemic, those populations were hit really hard. And so we pivoted to geographies that are having a little bit better time managing COVID in their communities. And so we've got quite a few new clients who are onboarding quite aggressively in North Texas, Puerto Rico, Ohio, Oregon, Washington, a number of other states. We're also working in Australia with the University of Notre Dame, Australia, where we have basically our wellness platform, which is really geared around physical and mental health, physical and mental wellness. And so that's deployed down there in Australia. And once they come out of the pandemic, we'll be moving forward with some other things in Australia. We are definitely rapidly growing. We have kind of graduated from that point where we had a lot of very small clients when we started. And we've generated enough clinical data and enough data on how we interface with the Medicare and Medicaid reimbursement system that now we have much larger clients, not only that we've secured ourselves, but who've come to us directly. So networks of skilled nursing facilities, for example, we have one network we're working with that we've announced who has 200 facilities, and we're working through deployments with those facilities. So we are at a point where we have that requisite clinical data that you need in healthcare. It's a very conservative market in order to attract those larger clients, and those larger clients tend to be easier to work with. It's no surprise that in a startup, your initial clients tend to be the most challenging that you'll ever work with, because no one else will work with them. And so they're restricted to working with untested new companies. But now we're at a point where we're really able to give the comfort level and the confidence to those larger clients. And so that's certainly beneficial to the business. Quick overview here that by the end of 2021, the year we're in now, so the calendar year, our gross margins should reach our target of over 75% with EBITDA margins of 45%. We have a very scalable business. We've designed the platform from the ground up to be extremely easy to use, very intuitive, a very lightweight layer to implement. And so that's where you see the difference between us having profit margins, EBITDA margins of over 45%, where somebody like a Teladoc or Livongo has profit margins that are in the 10 to 15% range. And so we have a lot more of a buffer than their businesses do if there were changes. We also offer a much more diverse product offerings. It's not just telemedicine or just a platform that does type 1 diabetes. We do quite a broad range of chronic diseases, as well as mental health and more kind of proactive mental wellness and physical wellness. We do expect that by the end of next year, we'll, at the latest, that we'll be in a position where we'll be able to uplist to the NASDAQ. Certainly because our largest customer base is and always will be in the US, it's really important that we get more of a presence in the public markets in the US. And we're certainly doing a lot more investor outreach this year in the US markets, because that's a shareholder base where they really understand some of the complexities around Medicare and Medicaid in a way that, even for us within the company has taken years to get to. So I think that uplisting to to a US exchange and a prominent US technology exchange will be important in the evolution of the company. And this is available on our website, so I won't kind of walk through that too much. And this is another slide that's a lot of numbers, but essentially what I wanted to capture in this presentation, this is our last slide, is that we are at a point where, we've really kind of got an inflection point that's coming this year, and we'll hit cash flow positive this quarter and profitability next quarter. So by the end of June 2021. I don't think in fiscal, so I'm generally always talking in calendar year. We have a lot of clients and patients in the pipeline. Certainly COVID has presented some challenges last year around certain geographies and some logistical challenges around onboarding, not on our end, but with clients who are really focused on massive outbreaks in their facilities and things like that. That's all going to start improving significantly in the next 3 to 5 months as the vaccine is rolled out in the US. And so this will be a year of really rapid and very significant growth for us. And we will certainly be keeping the market informed of all of our new developments through press releases and our own company webinars, as well as investor outreach. We've been very quiet for the last 2 years. There was a lot of uncertainty in the business for 2 years. So we really didn't do a lot of investor outreach, or what I guess more conventionally called marketing. Now we are really increasing our efforts around investor outreach because we have tremendous confidence in the data. We have a lot of visibility into the contracts that we have and the onboarding rates. And so we're at a point where we are starting to communicate more with the market, and very much looking forward to sharing our successes this year with all of you. So thank you very much for having me, Sophie and Paul and everyone else, and I'm happy to answer any questions.
Great. So we actually have quite a few questions for you, Lisa. Some you've they were submitted beforehand, so some you've covered, but let's just review a little bit. So you are in all 50 states right now. There's a presence in all 50 states.
Yeah, so with the with some of the contracts that we've signed, so in particular that network of 200 skilled nursing facilities, those facilities are all over the US. And so we'll be, actually I'm not sure they're in Hawaii, so perhaps it's 49, I'll double check, but I'm happy to go out there and look around, see if there's business there for us. Sophie, you can come with me.
I would be happy to, yes.
Yeah, but we do, we are starting onboarding now with the facility network, and we will be in all 50 states ourselves. We have a presence now, or in terms of our clients having a presence there, but we'll have patients in all 50 states very shortly, so. Yeah.
Okay, excellent. And so, oh, sorry, we just, so how, and I know you discussed going forward in the future, but how is the onboarding of patients going, and what's the revenue that it's producing now? For example, we had several questions on this. How many are you onboarding? How many have you onboarded in the past few months, and how much do you expect to onboard in the next 6 months? What does it look like from there?
Yeah, so I think we've shared this with the market that we provide our guidance in terms of revenue. We found that it was getting a bit confusing for people because some patients are on different modules, and so there's different revenue associated with each patient. So our projection that we provided to the market is that by the end of June, we'll be doing at least 1.5 million in revenue for the quarter. But basically every month from here on out, we are increasing the number of patients that we're onboarding. There were very significant challenges around COVID because some of our clients, in Texas, a lot of the home health agencies basically went on hiatus because they weren't allowed to do any home visits to prevent infection. So when they're on hiatus, they can't bill, so we can't work with them. So a lot of those clients will come back online this summer. Same thing in Florida, where their governor just kind of gave the state to COVID, and that was to no one's benefit. Really no one's. But in the other states, we will be increasing onboarding and therefore increasing revenue every month going forward for well beyond just 2021. But we do our forecasting in terms of revenue because we don't want people getting carried away and thinking that if we have this pocket of patients who are at $40, they're actually at 100. So we encourage you to follow our revenue guidance. We have not historically over the last few years, 2 years, I would say, publicly disclosed patient numbers. And so, this not being a form of permitted disclosure, I can't really address them here. But what I can definitely say is, look at our revenue guidance, and you'll see that we expect we'll have a run rate, not a run rate. We'll generate 1.5 million in revenue in the second quarter, so by the end of June. But by the end of this year, we expect to have generated 11 million in revenue. So we'll end the year at a significantly higher run rate than 11 million in annual revenue. But you can get a sense of a very significant increase in our rate of adding patients over the coming year.
So then, if I understand correctly, investors shouldn't really be looking at how many patients you're onboarding and really relying on the guidance that you're offering, because there is such a variance between the $40 and $100, correct?
Yeah, I mean, we had some patients originally who were on at $25, some of the real basic. We don't really have those anymore, but as we've gone through that kind of migration, it's revenue is what is going to matter. And so revenue is what we decided to focus on in terms of reporting. Customer numbers, client numbers, patient numbers can also be a sensitive metric in terms of giving your competitors that information. Yes. So, we always have to kind of balance what's a meaningful metric to report to our shareholders with what do we not want our competitors to know.
No, but that's good information for investors and for a lot of people on the webinar today, because it was a question that came up a lot about how many patients do you see going forward. But this way, I mean, it's clear, so that's good. Yeah. Okay, so besides cost saving, is there an estimate to increase the longevity for these people living alone, for persons living alone?
Yeah, I mean, it's interesting. My mother and stepdad are doctors who focus on patients who have health issues that are traditionally over the long term treated in the community. So my mom's a neurologist, stroke patients, head injury patients. They're retired now, but my stepdad's a palliative care physician, so care for the dying in their home. And what they've both always said is that, we're doing a really good job in the healthcare system of keeping people alive an extra 10 to 20 years versus say 50 years ago even. But what we're doing a really bad job of is giving them quality of life in those years. So we are at a point where I think, we're very good at extending life. And I wouldn't necessarily say that our platform is aimed at extending life, and we can keep people alive for a long time. And my grandmother lived in a coma for her last year in a hospital, and those aren't the kinds of lives we want to give people. We want them to have that quality of life where they're still able to get around, they can still breathe without having to be on an oxygen tank all the time, and that really translates to preventative care and what we're doing. So you probably would get, I would say, a little bit more time if you are really careful with your chronic diseases, so you're proactive in managing them. But where I think you'll really see the impact is that, this is going to keep people from needing to be admitted to long-term care, and this is going to keep people in their own home, and it's going to keep them functional and enjoying life as opposed to just surviving.
Mm-hmm. Oh, that's important. Okay, so another question: do you have the staff in place to handle the growth you're expecting?
We do. And where we may increase staffing a little bit is in the care management center. So we have medical assistants that we use there, and they do things like the annual wellness visits that we recently announced. They're a relatively low cost resource. So if we need to scale that side of the business, they're also very available, and they're not a population that's kind of hard to access. So we will be able to increase significantly if we need to. That won't have really any kind of significant impact on margins. But the core staff, we have a very strong clinical team, business development / sales, implementations, finance, that team is really well established. Most of our business development and implementation resources are located in the States, whereas our excuse me, core team of clinical and technical and management are up here in Canada, but we're not anticipating any significant increases in staffing other than on that care management side potentially.
Okay, excellent. What age? At what age does Medicare? Does a person qualify to receive the aid? Sorry about that.
Right. So Medicaid, which is not what you're asking, but I'm just going to differentiate between the two programs, is a
Okay.
state-by-state administered program. So, it all comes out of an overall tax budget, but Medicaid is state administered and every state has different rules. So in 20 states, patients who are on Medicaid qualify for our services. Until 2018, but really 2019 for usable codes, Medicare didn't cover remote monitoring. It was only Medicaid and only in those 20 states. But then beginning in 2018, but really in 2019, when they introduced more usable codes, Medicare, which is a federally funded program, began covering remote monitoring. Medicaid covers anybody below the poverty level or who has certain disabilities. Medicare covers everyone over the age of 65. So as soon as you turn 65, you qualify for Medicare. Lots of people who have the financial wherewithal will also use private insurers to supplement Medicare, but Medicare for everyone over 65 covers the services that we offer.
Okay, excellent. I have had a couple of questions about this. What's the status of your initiative with the First Nations in Ontario?
Yeah, so we've been working with government for 2 years, I would say, on expanding that pilot. We've also been speaking quite extensively to First Nations groups in other provinces. I will say that the government in Canada, while certainly very supportive of these kinds of initiatives, moves very, very slowly. All of these far north, remote, rural communities, and the First Nations healthcare there is third world at best. Significant challenges and budgets have been promised, but not a lot moves forward. So we do continue to feel that it's really important that the company do our part for First Nations healthcare in Canada, but selling into a socialized medicine system with government funding that's as conservative as the Canadian system is, isn't, from a business perspective, something you can invest a lot of time in. So, we definitely keep our hand in, but a lot of that effort is led by Brian Stortseth, our chairman of the board, who's very well connected in government. And so we do continue to make incremental progress, but if you look at even what we heard in Ontario at the last election about how healthcare would be revolutionized, I haven't seen it, certainly. So we have to recognize as a business that as much as we really want to make a significant difference here in Canada, it's a lot easier to make a difference in the States at this point. There's
Understandable, yeah.
Financially, from a business perspective, the States is where we have to focus most of our efforts.
Okay, so a couple of questions about competition. So what is the competitor landscape, and what are their stock increases or multiples versus yours?
Yeah, so I think there is no company in the community space that offers our full suite of solutions and that develops something specifically for the community market. Historically in healthcare, everything's been developed aimed at the hospitals, at the acute care setting, because that's where the budget was. So if you look at Vivify, who's a remote patient monitoring company that was acquired by United Healthcare about 2 years ago. They have a platform for remote monitoring, but it ties into hospital EMRs and electronic medical records. It's a very complex deployment, so they're very expensive upfront. There's a high capital cost. We have no capital cost upfront or down the road. They have a very complex implementation or installation, so they require and rely on hospitals' IT teams, who typically have between dozens and over 100 developers working within the hospital to deploy software and to support and maintain it going forward. And they're very expensive on a go-forward basis in terms of support and maintenance, Vivify software. So that won't work in the community. It works for the post-discharge patients, but that's a 30-day period. So their patients change over constantly. They have patients on the platform for 30 days and then they're off. But what no one had done when we came along, and still, our only real competition in the space, the companies that we take patients from on a regular basis are little mom and pop shops who develop something, could be an access database, or could be based in Excel, that's for remote patient monitoring. But the key in the community is you have to have something that's extremely usable, that lives in the cloud and is very intuitive, that can be deployed. We can, if you sign a contract today, we can have you up and running later this afternoon. It has to be something that's very usable by the patients. So, where a lot of companies have come up with, all of the major diabetes companies have come up with their own glucose meters and apps to monitor glucose. But these are apps that are developed by 20-year-olds in Silicon Valley for 20-year-olds. And so when you have the patients we have, I mean, most of the Medicaid patients we deal with don't have cell phones, computers, tablets, period. And that was certainly true working with the First Nations communities. And the Medicare population, as I say, our average patient age is over 75. So a lot of them don't have computers, tablets. I mean, certainly, my parents are very, well, relatively tech savvy and have tablets and phones. But a lot of this patient population, they're quite ill. So, they might have visual acuity issues. They might have issues with arthritis where they can't really easily navigate an app, even on a computer. They may have, in some cases, memory issues. And so for a lot of these patients, we use devices that actually not only take their blood sugar and their blood pressure, but talk. And so they might tell them in Spanish, it's time to take your blood pressure, it's time to collect your blood glucose, things like that. So what the patient sees is relatively low tech. I mean, we do have an app and a patient portal, and for the younger patients, especially on iUGO Well, they've got the whole slick interface. But that chronic disease population, we've got something that really meets them where they are from a technology perspective. And so the other sort of comparables in this space, they're not direct competitors, but would be Livongo, which was acquired recently by Teladoc, who's Teladoc is just this, and they offer virtual visits. Telemedicine on the whole is a very low margin business. So, when you invest in telemedicine only companies, you have to really watch that. And the key in telemedicine is huge volumes. And one thing we definitely noticed with telemedicine companies in the pandemic is a lot of them were giving their services away for free. So they'd announce, and this is part of the thing with patient numbers where it can get misleading. They would announce all these new subscribers, but they were all receiving the platform for free. So that's not going to translate to revenue. And especially post-pandemic, they're going to lose a lot of those patients. But so Livongo was acquired by Teladoc for some kind of enormous multiples in one of my investor presentations, but a very significant multiple. And excuse me, Livongo is not making money yet, and they have raised a lot of money over the years. They focus on type 1 diabetes, so they do remote monitoring and care management for patients with type 1 diabetes. That's 10% of the diabetes market. The other 90% of patients are type 2. That's what we focus on, and what we've heard traditionally. So there's lots of these little companies, or even large, like Baxter companies, who have apps that will monitor one chronic condition, so diabetes, or you have a wearable Holter monitor for cardiac disease, and there's an app that monitors that. But what doctors and patients have consistently told us is they don't want to interface with different platforms for their different conditions. And most patients with chronic diseases don't just have the one. That's fairly rare. So Livongo's business model is very high touch. They have a lot of patient contact with other human beings doing case management. And so it's not as inherently scalable, and it's much more expensive, which is why their margins are down, almost in the single digits. And they're going through a very complex integration with Teladoc right now that's kind of got both platforms a little, off their footing for the moment. But, I think their multiples, their valuations, which are sky high, are a very good indication of how the market is valuing virtual care. And I think as over the next year or two, particularly with us, as we get to cash flow positive and profitability and start to show tremendous growth in our revenue, we'll start to see that kind of recognition in the market. There's more of an understanding of what we do and the value of that now than there was even a year or two ago. But we have very significant competitive advantages over these companies that have already had very compelling, not so much exits, but very compelling valuations based on much narrower products that address a much smaller patient population.
That puts you guys in a really good spot. What about analyst coverage? Any analyst coverage yet?
We don't have analyst coverage yet. I do expect that that'll come certainly by the end of June, hopefully sooner. I do have some analyst conversations coming up in the next 2 weeks. So I think we're at a point, to be honest, when the business was facing a lot of uncertainty over the last 2 years, I just didn't feel that it was a good idea for us to be spending a lot of time with analysts when we really couldn't give them anything concrete. Now that we're at a point where, I'm an engineer by training, and so I make a lot of decisions based on data. And now that we're at a point where I have really good visibility into the rest of this year and beyond, and we have the contracts and we have these larger clients who are more than happy to speak to analysts and have spoken to a number of our partners and investors. I think we're in a much better position to engage with that analyst community.
Okay, and institutional holdings?
I would say we're basically entirely retail held at this point, maybe some small institutional holdings, but that's definitely part of our focus with the investor outreach this year, and part of why we engaged Lytham Partners in the US to do IR for us. They have had a lot of meetings this week, and I have a lot over the next few weeks of one-on-ones with institutions. And in some cases, they're relatively small family offices. In other cases, they're institutional funds that may have a considerably larger pool of capital under management, but they're very well connected with the institutional investor community in the US and very good at putting you in front of the right institutions for your stage of business. So I think we'll see a big change in our investor mix over this year.
Okay, excellent.
We don't want our retail investors to go away. You've been such strong supporters of ours, and we're so grateful for that.
So there's a question here. So if everything is, correct, is it possible to think that Reliq could, you're going to love this one because it's about invalidating patients again, 10,000 patients per month? Is that a possibility?
Oh yeah, I mean, definitely what we've done, whether I should be saying this or not, I'm going to, what we've done as an organization is ensured that the software and the team are prepared to add tens of thousands of patients per month going forward. So when we work with some of these larger groups, and as I say, we have a very full pipeline, and the pipeline is increasingly, these larger clients. Not that we're neglecting or refusing the smaller clients, but we are definitely at a point where we've evolved into these larger clients, and some of them will move slowly, particularly during a pandemic, but ultimately they're going to hit a point where they're in a great big hurry and want large numbers of patients onboarded very rapidly, and we're definitely set up for that.
Okay. So one last question. It's actually a two-part question. Do you consider Amazon's entry into telehealth field a risk or more of a sign that the field is due for a major surge? And the second question to that, would Alexa be compatible in the future as well?
Yeah, no, I mean, Alexa is compatible now. You could use Alexa with our system. What we found early on when we were using Alexa is that the elderly patients found it startling. So they kept forgetting it was in the home, and then it would scare them, especially if someone accidentally set the voice to a male. We found that really didn't work. There was a man in the house. So I expect that, we've talked a little bit about iUGO Home in the past, and we'll certainly be talking more about that in the relatively near future. That platform, it works in institutional settings as well as in homes, but as we later in the year move towards providing access to kind of direct to consumer, that's where I think you're going to see more of these voice systems will be more popular with some of the more tech savvy patients. Definitely we're compatible with Alexa. In terms of Amazon, I've always felt, and this is not a prediction, so, my full forward-looking disclaimer, but I've always felt Amazon is a logical, there's always consolidation in our space. I've always felt Amazon is a company that would be someone who would be very interested in a company like ours once we kind of reach the type of valuation and patient population size that we expect to reach, in the coming year or two or beyond. And they're certainly very attractive if you're looking at the trend to consolidation. They have the deep pockets. I think what they've been doing in healthcare really plays to their strengths in logistics. So they acquired PillPack and they've got a number of other offerings. What Amazon's not interested in doing, and we know this from working with them on their Fire tablets, is HIPAA compliance. So the regulatory compliance that would be involved in doing what we do. So I don't expect Amazon will ever launch their own product or offering that would compete with what we do. But I think they definitely recognize the value of healthcare. And I think, something like what we do is a key missing component in what they're looking to offer the market. It's basically acquiring a customer base, if you were to engage with a company like us. So I think they and the other tech giants have all expressed interest in tech, but what they're really not comfortable doing is stuff that directly touches patients like what we do, because they don't have the expertise. It's highly regulated, it's very complex, and they don't have the kind of credibility in healthcare that it's a very conservative market that market would require. They do see the tech giants as incredibly valuable for some of their innovations, but in terms of directly touching patients, I think that's a bridge too far. So we aren't worried about them as a competitor. We think it's a great sign that they're interested in healthcare. I think that's a real validation of the healthcare market as a growing space. And maybe down the road, they're a partner or something more, but not a competitor.
Well, that's great. I'm sure Paul has a question or two, and then we can wrap it up. Oh, Paul, you're on mute again.
Yeah.
Here I'm back now,
Yeah.
I think, right? What are your blended margins, like average? Because you have different products, right? So
Yeah.
you mentioned before
Yeah.
that margins are small normally in this business. So what are your blended margin, average margins?
Yeah, our average margin by the end of this year will be 75%. I think we're around 60 right now, but it's definitely increasing. It's very much an economies of scale business, and so once we reach kind of the tipping point around the middle of this year, and maybe into the fall, we'll be at our kind of target margins of 75% or more gross and 45% or more EBITDA.
Perfect. And you touched on earlier about a NASDAQ listing.
Yeah, I think it's important. I think when you uplist, wherever you uplist, it's really important to time that properly. You don't want to go in too early and be, kind of the redheaded stepchild or whatever that expression is on the exchange, and yep. You don't want to be ignored. So you definitely want to get to a certain valuation. But I do think it's really important that you're listed on the right exchange at the right time. And I think the right time for us for a NASDAQ listing is probably next year. And I think our valuation will be at a point where we can attract the attention of the buyers who frequent the NASDAQ. And I think it's really important to us that we uplist in the US because that's where our largest customer base is. And not that we as Canadians can't understand the US healthcare system, but we didn't grow up in it. And so, US investors, I think, are very excited about healthcare, and that continues to increase as Medicare and Medicaid continue to make a lot of changes that are favorable to companies like ours. So I think it will be important to have that US listing sooner rather than later.
No, exactly. All right, perfect. That's about it for me. I mean, Sophie asked most of the questions that I was going to touch on. So are we done, Sophie, do you think?
I think we are.
All right. Well, thank you again so much for having me. And again, my apologies for last night cancellation. That has never happened to me before. But yeah, it was unavoidable. Trust me.
Well, we're happy to have you back.
Yeah, Lisa, thank you so much. Really appreciate your time. And thanks to everyone who logged on today. We had a very good crowd, great crowd. So
great, wonderful. Thanks so much, everyone, for attending. And don't forget, if you have follow-up questions, please direct them to ir@reliqhealth.com, and we'll make sure we get those answered.
Perfect. Thank you so much. Take care.
Thanks, everyone. Take care. Stay safe.